Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
I love to have doctors on our show because we find out so many things. So many of you have a great doctor, but they don't have much time to talk to you, and that's why I love to have them on the radio show. I get them for almost 30 minutes, so we're going to just drain them dry. Dr. Ahmed Osman is here. He's a cardiologist, but he has a specialty, and it's called electrophysiology. So he'll tell you all about that. Okay, so it's a busy time for you, but tell us what the difference is in a cardiologist and what you do.
Well, thanks for having me here today. So cardiology is basically the specialty in medicine that treats all sorts and forms of cardiovascular disease and heart disease. And I say cardiovascular because it's also important to remember the heart is the pump, but that pump serves a very, very wide vascular bed that goes all the way from the brain to the tip of your toes, and the diseases that affect the heart also affect all of these vessels. So it's a big spectrum of diseases that is treated by the cardiologist these days. So within that subspecialty, there is further subspecialization, and what cardiac electrophysiology deals with is basically the problems and the diseases of the heart rhythm. So the heartbeat is a very, very small electrical impulse, and the heartbeat starts in the top chambers of the heart. Then there is a travel that travels down to a junction box, if you wish, that basically allows the pumping chambers to act very rapidly and cause the pulse. So that's the any disturbance in that very nicely tuned electrical circuitry and superhighways, because they really conduct very fast, that heartbeat leads to palpitations, a sensation of a rapid heartbeat, sometimes fainting, and there are some very dangerous potential rhythms that we do deal with on a daily basis. So in a nutshell, the specialty or the subspecialty deals with abnormal rhythms of the heart.
And when you think of that, this doesn't just happen casually, right? I mean, it's a disease. This isn't, you were born a certain way, and then as you start to grow up, things happen.
Correct. Yes. The majority of diseases that we deal with in adult cardiac electrophysiology have to do with things that we acquire. There is, however, a certain proportion of diseases or rhythm problems that are really not anybody's fault. So some of them are congenital, and some of them are things that we are, an extra muscle fiber, for instance, that can add an extra connection between the top and bottom chambers, can cause a very rapid heart rhythm. So this is something that you are born with and typically manifests at an earlier age. There are also certain things that just happen with time that are, not really related to a specific risk factor, because we'll talk about risk factors and how to best protect ourselves from problems from the electrical standpoint. But there are things that can happen despite us being very good with our lifestyle and making sure that we treat all our potential medical problems.
I was going to get to that. So, is your family alive?
Yes,
okay.
Both my parents are alive.
Good.
And thank you for asking.
Okay, so I'm going to ask about them. So what do you tell your mother and your father that they should be doing?
So I clearly tell my parents, my family, my friends, all my patients that prevention is really worth looking into, as opposed to waiting for a problem to happen and then saying, oh gosh, I wish I had done this 20 years ago. And what's funny about electrical problems is that the majority of the electrical problems are based or are sequely to the main or common cardiac problems, cardiovascular problems. So if you there are things that are modifiable that we can do. And the things that we can do is avoiding smoking, for instance. If we have a high cholesterol or high lipid or abnormal lipid levels in the blood, then we want to make sure that we treat those very effectively nowadays with a lot of different medications.
Is that where the fat is in there? And
yes.
That's what we call that?
Exactly. So I don't want to use the word cholesterol, because every time we say that, people say, well, now they just found out that cholesterol is good. Well, we never said cholesterol is bad. Cholesterol is just one component of this, what we call an abnormal lipid profile. So if you have just the right milieu, just the right environment for deposition of plaque. Plaque is really, calcium and fat deposition in any of the vessels within the heart and outside the heart. That's what causes the very large proportion of the cardiovascular problems that we treat on a daily basis.
And can you get rid of that plaque?
You can treat it very, very aggressively to stabilize it and prevent it from progressing. And to a very slight extent, you can actually have that regress a little bit. But you really want to start early on. We identify patients who have lipid problems early on in life, and we treat those. And a lot of it is genetic. So yes, we want to avoid eating a high carbohydrate diet. We want to make sure we don't want to end up with obesity problems, but we also recognize and have to accept that a lot of it is genetic. And if you do have a high cholesterol level, high lipid, but for using cholesterol again, but high lipid, abnormal lipid profile, then we should treat those with medications.
And so, of course, when someone comes to you, are they coming to you as a cardiologist or as an electrocardiologist?
So, no, I actually have been practicing electrophysiology almost exclusively, and there are certain very common electrical problems that I'm sure you may have heard about, such as atrial fibrillation, which is really the most common abnormal rhythm problem of the heart that I deal with on a daily basis. And just to give you a perspective, 1 in 4 of us will have atrial fibrillation in their lifetime. So it's a very, very prevalent problem. If you get to the age of 80 and above, it's about 10% of the patients of the population that have atrial fibrillation.
And yes, because I've been hearing more about your years. That wasn't something we even heard.
So we're recognizing it a lot more. And we have actually gotten so much more effective at treating it and helping our patients live longer and functional lives. So, and that's what really is exciting in my field. We've had, since I've started practicing, there's been a tremendous amount of advancement in what we do and how we do things, how we treat these problems, and how we can best help our patients feel better and function better and avoid potential life-threatening problems.
So if you're living with atrial fibrillation, what do you feel?
So, good question. So the way atrial fibrillation manifests is with a sensation of an irregular heartbeat. And it can sometimes manifest as shortness of breath, more fatigue. You feel the heartbeat or check your pulse and you see the heart rate is much more increased than usual. But in maybe 20 to 30% of the times, it is totally asymptomatic. So it means that it's just not affecting the patient too much. Nevertheless, we have to be very careful and make sure that we treat those situations very aggressively as well. And I'll tell you, the way we approach atrial fibrillation basically there's 2 components to how we treat it. The main issue is obviously recognizing that once these upper chambers where the atrial fibrillation comes from, the upper chambers of the heart, are not beating regularly and fully like they should in a normal heartbeat, they have this atrial fibrillation problem, the blood can stagnate in those upper chambers, and that can lead to the formation of clots. So the main way that atrial fibrillation can hurt our patients is by causing strokes, because those clots can break off, travel to the brain. So any patient with atrial fibrillation, and any of your listeners who has atrial fibrillation, should always go and ask his doctor, am I at risk for a stroke or not? Because the way we fight that is we use anticoagulants, what we commonly call blood thinners. And those blood thinners really prevent any clots from forming inside the heart.
Okay, now I have a friend that had this, and he had to have like electrical something. Tell us when you find someone, what do you do?
So what you're referring to is the other part of how we manage this problem, and that is when we have symptoms from atrial fibrillation. In other words, it's either bothering our patient very much, it's causing him limitation in his functional status, or it's causing deterioration of the overall heart function, then we have to do something about it. And what we do is typically we do what we call rhythm control. Rhythm control means that we want to bring the rhythm back to normal. The So a couple of things on that. The earlier we try or we restore normal rhythm, the better, the easier, and the more effective we are in treating this disease. If we're going to wait for years and years of atrial fibrillation and then decide that we're not really feeling too well, then it may be too late to do anything about it, and it may be more palliative intervention rather than curative intervention. So the earlier we recognize atrial fibrillation, the earlier you see an electrophysiologist that can perhaps talk about more invasive procedures to cure the problem potentially, then the better we are. So what he may have had is either a cardioversion, which is just a simple resetting of the rhythm. That's an external shock under anesthesia. Or he may have had some more intervention, which is called an ablation.
He had both. First he had the first. But let's go back to when you say a shock, how do you do that?
That just resets the rhythm. It silences the chaos, the electrical storm that's in those upper chambers, and allows the normal pacemaker of the heart to resume its activity and hopefully stay in that normal rhythm. Now we have to do more than just resetting, because resetting is just that. There are medications we use to help maintain the rhythm. There are also, like I mentioned, an ablation or a procedure where we can really get to the bottom of where those triggers are. And lately, actually, we've been very, very excited with newer technology that allows us to tackle even the tougher cases, the ones that have been a little bit longer in atrial fibrillation, where not only you have those triggers, little firing points within the back of the upper chambers, but also the drivers, what keeps it going, what the maintaining mechanisms for atrial fibrillation. So there's a lot of advances that we're very, very excited to be able to offer our patients these days.
What is the operation like for ablation?
Good question. So it's an outpatient procedure. It is not a surgical procedure. It's really an endovascular, meaning that we just use catheters. We go from the groin all the way up into the inside of the heart. We're able to use very advanced mapping systems that gives you very good functional, electrical, and anatomical information, and we can navigate within the upper chambers of the heart and isolate the triggers, which really are most commonly found in the back of the left upper chamber or left atrium. So that procedure or that part is called pulmonary vein isolation. So your listeners may have heard of that. That is the cornerstone of any intervention for atrial fibrillation. And that's where we isolate or clearly electrically eliminate the triggers, which is what really causes atrial fibrillation early on in time.
And he actually had to have it done twice.
So it is not an appendix that I can excise and then the problem is over, unfortunately. And we are, so what we do is we do eliminate the triggers. We do look, and what we do, we don't only just leave it at that. We look at other potential areas of triggers. And like I said, in many patients, we do now find that there are drivers for atrial fibrillation that we address with ablation as well. But it is a very gradually progressive disease, and the longer we stay in atrial fibrillation, the more I want to call permanent changes that can happen within those upper chambers, scarring that occurs in those chambers that doesn't allow us to cure it completely. So in many patients, we cannot just get rid of it, and we have to understand those limitations. And we can only see that when we map the heart and we kind of get a very in-depth assessment of how extensive the scarring is, how large that atrium is, and at least give our patients the chance to eliminate the major triggers and see how they do. The majority of patients have a lot of relief from procedures that we do, and it does modify that progression. It does slow down the recurrence. It does give them a significant improvement in quality of life, and that's been shown in a lot of the studies that have been conducted in the last 10, 15 years.
Are you using robots for any of this? I mean...
Not yet. I wish I had a robot, but I think there's nothing better than human hands at this stage.
So when you're seeing
yes.
some of the operations, you're doing it, but a robot is getting in there, so you're not doing that.
So there are very early, there is early technology that allows robotic intervention. It is not as good as human hands yet. So I would not want to have a robot do that procedure for me, or even a robot under somebody's supervision do that at this stage. But
so
it will
robot,
get better.
Get back in your box.
It will get better, I suspect so. And there are also some magnetic navigation tools that may be used in the very near future. That are actually used in many areas that may come over and hopefully help us do this.
Well, this has been so interesting. I just always forget who's talking, but everybody always says, tell us who we're listening to. It's Dr. Ahmed Osman, O-S-M-A-N, and he is a cardiologist, but his specialty is electrophysiology. And if you want to contact him, you can actually go to, he's Florida Heart Rhythm Specialists, and they are in Fort Lauderdale. To make an appointment, go to 954-678-9531. And you can also go to his website, which is Florida, FLAHRS.com, right?
That's correct.
So it's very important, of course, you start probably with your primary physician. And, we have some things here.
So, yeah, I actually...
Oh, I love this.
Remember,
that's what I want.
I talked about preventing strokes, which is really a key portion of what we do. Be careful, it's a little sharp. I'll get it out for you.
Okay. Oh, I love this.
So this is a little device that's called the Watchman. And there are patients that do very well with anticoagulation, with anticoagulants or blood thinners.
Whoa,
and can stay...
so pretty. It is really pretty.
So it's a little umbrella, isn't it?
Yes.
So it's a little bit of a show and tell, but it really is an alternative to anticoagulation in patients with atrial fibrillation who are really having a lot of problems with blood thinners. So patients who typically have had either bleeds in the gastrointestinal tract or bleeding in the central nervous system, for instance.
Because the blood is too thin, but yet they need it.
Exactly right. So we're trying to prevent a stroke on one hand, but the blood thinner can cause problems on the other. So luckily, and we're really very excited to have an alternative for those patients. And the fact is we can use this little device to deploy it in the left atrium and seal off the area where the vast majority of clots form. And that way our patients come off blood thinners. Coumadin, the newer agents that we have, all of these can be discontinued safely and still protect our patient from having a stroke.
So how does this sit? I know people, I wish this were TV, but how do we... As a matter of fact, I'm actually going to have you hold that up because we're putting this on YouTube anyway.
Ah, good.
And so I'm going to do that, and then we're going to show that.
So these are very small devices that basically are deployed through a catheter again. This is all endovascular. And what we do is we have this is all collapsed when it goes into the body.
Oh, I was wondering about that.
Yes, it's all collapsed like so within that sheath that we use. And once we have it in a good position right at the entrance of that pouch, it's called the appendage, the left atrial appendage. Once we have that in a suitable position, we deploy it, and it basically seals it off completely. So no clots can form and travel to the brain from that appendage.
So that's a fairly new?
It's fairly new. We've been
Who makes that? Medtronic?
It's one of the companies, it's called Boston Scientific, and we basically have been lucky to have the largest experience in Broward County with this device for now a couple of years, and it really makes a significant lifestyle change for our patients because they've been miserable with bleeding and recurrent either blood in the urine, blood in the stools, either just the bruising, the skin problems. And it really is quite a welcome relief for those patients. So
this has really nothing to do with stents.
Not at all.
So people who have had that, no, this is not for you.
This is for atrial fibrillation patients who are on anticoagulation and are having a lot of problems with anticoagulation. So we can,
and that hooks in. I can see the.
That's exactly. It stays attached from within, and over the time of several weeks, it gets covered by endothelium. So the natural lining of the heart kind of covers it from inside, and that's
amazing.
It. And it stays there. So really very exciting advance. There are some other devices coming online that we also will be able to offer, but it really makes a big difference for a lot of our patients.
Now, people see you to get a A pacemaker. Is that true? Okay.
Good.
Now we're going to get into the pacemaker.
So we're shifting gears a little bit. So pacemakers are
Tell us about that.
for slow heart rate. So if you are having symptoms because of a very slow heart rate, and slow heart rates can be from different causes, but sometimes the junction box is not working too well. The AV node, it's called the AV node, is not conducting well. Sometimes the normal pacemaker that I was mentioning earlier is not firing fast enough, and it is really something that can just happen with time. Then we talk about pacemakers. So pacemakers are only for symptomatic bradycardia, which is the word that means slow heart rate. So if you're having symptoms because of a slow heart rate, that's when we discuss a pacemaker.
So what is a slow heart? Tell us how you know what that is.
So you feel weak, dizzy, you can't do as much as you had been doing traditionally, you get very short of breath real quick when you get up and try to do things. It can get more severe with patients feeling dizzy, lightheaded, almost pass out, faint, and that's when we really want to talk about a pacemaker. So pacemakers will keep the heart rate from dropping too low. And traditionally, pacemakers it's a very minor surgery, and it's really a small incision in the upper chest area under the collarbone, and we thread those very thin leads or wires that go all the way into the inside of the heart, and we insert those leads into very specific positions in the heart, in the upper and lower chamber, and basically deliver an impulse, an electric impulse. If your heartbeat is not doing what it's supposed to do on its own, then that pacemaker will basically supplement the heart rate to make sure that the heart rate does not drop too low.
Now, how do you control that?
So it can be controlled remotely, wirelessly, from outside. We can have a wand, what we call a wand, and a programmer that can talk to the pacemaker externally. And we now have a lot of fancy technology for remote monitoring. So if you're at home, you have a little gadget that you plug in that basically checks on you without you even knowing and report to us if there's any major problems.
And so the pacemaker you have in your hand is now this is really interesting.
So this is a leadless.
I can't get over this.
A leadless pacemaker. It's another exciting development in the field of electrophysiology that we've witnessed in the last several years. And it's a pacemaker that we insert inside the heart without having to put in any leads in the veins. So the main issues that we've had traditionally with pacemakers really have to do with the leads that go through the veins all the way into the inside of the heart. They either block veins, sometimes there's a risk of infection, and there are a lot of patients that don't have suitable veins, like patients on dialysis, for instance, are commonly so. So this is another chapter in cardiac pacing that's being written with this leadless pacemaker. Right now, it's just a single chamber pacemaker, one chamber, so the bottom chamber. But there is a lot of development going on to have a two-chamber pacemaker with the same technology.
Now, how do you get this in?
It's a very minor procedure. It's through the groin, through the vein, all the way inside the heart under X-ray, and we have these little tines that you see there. They basically attach from within, and we can talk to it from outside the heart. So this is another new,
let me take a picture of that too. I'm going to do that. I mean, Excellent. This is fabulous. Now, hopefully, Dr. Osman will be able to be one of our fabulous guests at our next Gear Symposium in March, because he'll bring all these. This is what I love about it. So let's see. Is that real? I don't think. Why don't you hold it straight, right, like that? Because it's so unusual. Yeah, it's really very unusual. I love this. So this actually is the next version.
The next chapter.
What is the other one now that is going in? Is it how much bigger is it?
Well, this is about less than 1% of the volume of the regular pacemaker now. So it just gives you a perspective on how small this is compared to the current one. They are. I'm not saying that we do still use a lot of the traditional pacemakers, because a lot of the patients that we see require dual chamber pacemakers. So not everybody will get a leadless pacemaker at this stage. But it is certainly a welcome addition to what we can offer our patients.
Now, so a lot of this really is due to the various degrees of what people's body looks like inside. You just can't. It's not a one fit all. You decide, and then you know. And And once it's in, people don't feel that, do they? They don't know anything.
Not at all. The whole point of having pacemakers inserted is to have you resume your activities of daily living to the fullest extent and have you continue to enjoy what you do. So yes, the limitations are really minimal in the sense that you should not be close to any nuclear reactors. So that's one major one, but I don't know how many patients how many of your listeners have access to nuclear reactors. The other thing is arc welding. You should not be using arc welding.
No, but there also, wasn't it before you couldn't even go into an MRI?
Well, that's no longer the case. All of the new pacemakers that we have can be used within the MRI environment. So they're MRI safe or MRI compatible. And that's another great advancement. So I'm happy you're asking all these great questions because that is actually a major advancement that we've really witnessed lately. All of the devices that we have, both pacemakers and defibrillators. Didn't we mention defibrillators?
No, we didn't.
Uh-huh.
Good.
So
Let's go.
That's kind of a segue to the next page here.
Right.
What are defibrillators? Defibrillators are devices that are implanted to be either a airbag, if you wish, to deploy should the patient have a life-threatening rhythm. So there are certain patients who are at risk for life-threatening ventricular rhythms. So these rhythms now are not the atrial fibrillation from the top chamber. These are rhythms that come from the bottom chambers of the heart. And some of these rhythms can lead to sudden death. And that's where these defibrillators come into play. They are devices that are literally like paramedics with a lead inside the heart that would terminate a potentially life-threatening rhythm in patients at risk for that.
There's so much more to say, but we will have Dr. Osman back, and I just want to thank you so much. I learned so much, and I'm sure our listeners did.
You're more than welcome. Thank you for inviting me. Always good seeing you, Anita.